My name is Dr. Clement Nzuka. I'll be talking to you today about a specific type of a headache, the one that attacks the periorbital region. When I say periorbital, I mean the orbit of the eye. And sometimes it gets clustered at the back of the eye, right there. And this type of a headache is called a cluster headache, number one, right? And you must tell me if this is your headache. Periorbital, sometimes behind the eye, and it's unilateral. It will take one eye, the one on the left or the one on the right. So it's unilateral. And it might be confusing by having, a differential diagnosis. You think this is the cluster headache, whereas it's just a sinus infection. And you say, this is a cluster headache when it's trigeminal neuralgia. You know the trigeminal has got three branches. It's got an optic branch that goes up, so it will be a headache because it is the neuralgia it goes towards the heart. It is optic. That's the optic component, and the other branches are maxillary, and the last branch is mandibular. So those are not less confusing, but the one that's confusing is the one that goes up, goes to the eye of the optic branch. And so it will be a headache, and you'll say, oh, this is a cluster headache, when it's an optic nerve neuralgia or a trigeminal neuralgia. Sometimes it can be a reader's paratrigeminal neuralgia. What's that? It is the same as the one that we cited, that one of the trigeminal, and the optic component being the most prominent one, which is confusing. But this one, in addition to the optic branch that has got a neuralgia, it has got the Horner's syndrome. Horner's syndrome, what is that? When you have one eye with a ptosis or a drooping eyelid. Drooping eyelid is called a ptosis. And then if you look at the same eyelid, or the same eye that has got a drooping eyelid, you notice that its pupil is constricted, and that's called miosis. A drooping eyelid and a constricted pupil, that constitutes a Horner's syndrome. But this is in addition to the what? To the neuralgia of the optic nerve. Now, we know that the optic nerve is a branch of trigeminal nerve. It has got three components: the optic branch, it has got the maxillary branch, it has got the the mandibular branch. But the ones which are confusing us is the optic component of the trigeminal nerve. Right. Because that one, if it develops a neuralgia, you'll think that, oh, this is a cluster headache. So it's important to think about the diagnosis, the differential diagnosis. What else can you think about? We said sinus infection as a differential diagnosis. We said, okay, both types of trigeminal neuralgias, right? The readers, and when we say readers, we know that it has got the Horner's syndrome as a component of this neuralgia, or this trigeminal neuralgia. Is that all? That is good. Then we say, how do we manage this condition? What do we do exactly to manage a condition like this, where you have a unilateral headache that is periorbital in origin and also goes behind the eye, and we say it is clustered there, so this is a cluster headache. How do we manage it? Management, you will be surprised. You have to think of oxygen inhalation. Oxygen inhalation drives it away. So when you're treating this condition, you have to think of oxygen inhalation. Number two, what else would you think about? Because it is localized, you think of a local anesthetic. And local anesthetic agent, straight there as an injection. You, of course, periorbitally, you won't go to the eye, you go periorbitally, right? With a local anesthetic. Is that all? Local anesthetic, inhalation of oxygen. Is that all? You can think of ergotamine. Ergotamine. If once you think of ergotamine, you think of ergotamine as a tablet. And when you use ergotamine as a tablet, you could use an injection, dihydroergotamine. That's an injection, but still it's an ergotamine. And the last thing that you will not forget is sumatriptan. That's medically, it's a medical management of a cluster headache. That is good, because you can actually now abort this headache. Abort, in other words, get rid of the headache. You can abort the headache using oxygen inhalation, using a local anesthetic, like lidocaine, for instance. Local anesthetic, like ergotamine as a tablet. You can use the you can use dihydroergotamine as an injection, and then you can use your sumatriptan as a tablet. Then that is medical management of the condition. That is to abort the headache. In other words, get rid of the headache. But you ask yourself this one question: is there anything that you can do as a preventative therapy, as a prophylactic therapy? The answer is yes, you can do a lot as prophylactic therapy. You can use, for instance, a calcium channel blocker. We know that calcium always promotes the contraction of the muscle, in particular the smooth muscle. It will promote the contraction of the muscle. And then that can cause a headache, that by itself. But now you can use a calcium channel blocker. Now, you ask yourself, which calcium channel blocker is suitable? Because there are two types of calcium channel blockers. There are those which are called dihydropyrimidines. There are those which are called non-dihydropyrimidines. And the dihydropyrimidines that we know are the ones that we use for hypertension, that is amlodipine, nifedipine. We use those for hypertension, but we don't use them for a headache. The non-dihydropyrimidines, you use them for a headache. Which non-dihydropyrimidines are you thinking of? I'm thinking of diltiazem or cardizem. Diltiazem, it's ugly to use it. We can use it, but it's not very nice to use it because you use it as an injection. Well, no. You use it as an IV, as an intravenous injection, instead of using a tablet. But verapamil is the most suitable one. Verapamil is the most suitable one because that one you use it as a tablet. And you take 180 milligrams of verapamil, and it tends to work very well. And if it is tolerated, you can use 360 milligrams, which is just double 180, double one, in other words, the one tab that you use at night. And you can use that if it is being tolerated. But one has to have this in mind, that verapamil has got a negative inotropic effect. What does that mean, negative inotropic effect? It doesn't encourage contraction of the heart. That's unfortunate. You're trying to treat a headache here, a cluster headache. You're trying to use it as preventative therapy, as prophylactic therapy. But now you have a problem that this drug that you're using, verapamil, has got a negative inotropic effect. So if you have a problem with the heart, there's something with the heart is not doing that well. The heart is not, at its best, contracting well. So to use verapamil would be disastrous. So the best is to hand the patient over to the cardiologists, to the physicians, the people who are used to using verapamil. I'm an OPD doctor. I'm not going to treat that patient with verapamil at an OPD level. I'm going to hand the patient over to the specialists, that is the cardiologists. Let them have a look at this patient. And of course, I will make my own comments while I was trying to use it as prophylactic therapy and see if it is suitable for this patient. You can do your ECGs and all that to check whether the heart is doing well. If your heart is doing well, then still the decision has to be taken by the cardiologist or the physician. At an OPD level, you don't get into decisions like that. All you have done, you have said, as prophylactic therapy, you are using verapamil at 180 milligrams nocte at night. Right? So that's very good. Then you go on to say, is that all? Is that all? Is that how you use it as prophylactic therapy? Is that all? It's just this dihydropyrimidine that is, or non-dihydropyrimidine, this non-dihydropyrimidine, which is verapamil. Is that all? No, the answer is no. If you have lithium carbonate, you can use lithium carbonate at 600 milligrams daily, up to 900 milligrams daily, as prophylactic therapy, as a preventative therapy. And also, if you are treating the condition, you can still use a steroid. A steroid, if you have to use a steroid, you have to think of prednisone. Now, prednisone starts at 60 milligrams, and you taper it down to 40 milligrams. You taper it down to 20 milligrams over 3 days. And I can tell you, you would have done wonderful work. Sometimes people start at 60 milligrams, they go to zero. But that one is over months, over 3 months, going to zero, tapering it down to zero, but starting from 60 milligrams. But I think if you do it for 3 days, it will be 60 milligrams, 20 milligrams, or 60 milligrams, 40 milligrams, and then 20 milligrams over 3 days. And that's good. Just go down to 20 milligrams, 20 milligrams, 20 milligrams, like that. That is 60 to 40 milligrams, 40 milligrams to 20 milligrams. Right. So that's what you do. But sometimes you get a patient who's got rhinorrhea. You know rhinorrhea, that's a running nose. Rhinitis, presents with a rhinitis, a running nose. And those patients, they normally present with a lacrimation, tears. They have got tears. They start tearing and all that. If you have that, then you think of an allergic reaction. There must be an allergic reaction. So once you think of an allergic reaction, then you think of an antihistamine. Antihistamine that you can use is periactin, 2 milligrams TDS 3 times a day. And I can tell you that patient will be, if you are treating a rhinorrhea and lacrimation, and this is accompanied by a cluster headache. And so this you want to make sure that you treat the patient very, very well. And having in mind that the patient might have different conditions, like for instance, the patient might have a heart that is not doing that well. And if the patient is having that, then you have to be careful about your calcium channel blocker. Calcium channel blocker being what? Your calcium channel blocker being your verapamil. Instead of, you won't think of diltiazem. In fact, diltiazem has got, you don't like it because it has to be used intravenously. And besides, that's not the one that we choose. The one that is doing very well is verapamil. And that's it. So thank you very much for listening to me. And this was just a cluster headache, going over a specific type of headache known as a cluster headache. And when you think of a cluster headache all the time, you must always think of a periorbital pain, or a pain right behind the eye, and it's always unilateral, as opposed to the other types of headaches that we discussed. Thank you very much for listening to me.